Hey, this is Katrina Bird, or my patients call me Dr. Bird, and welcome to my channel. Today we're going to talk about urinary tract infections, so let's get started. So first we want to start off with a few key definitions. This is going to start off very basic and going to get more complicated. It's important that we remember the basics so that when we're thinking about the more complicated cases, it will all make sense. So we don't want to forget the basics when we get to our more complicated patients. So first, pyuria are leukocytes or white blood cells in the urine. Bacteriuria is bacteria in the urine. Super basic. So what is a urinary tract infection? So we define that as when you see pyuria and bacteriuria in the setting of symptoms. Symptoms being painful urination or dysuria, increased urinary frequency, some like lower abdominal pain or suprapubic pain. Sometimes if you're thinking about an upper urinary tract infection, it's going to be flank pain, so forth and so on. We call that urinary tract infection. However, if you have pyuria plus bacteriuria, but the patient has no symptoms, like no increased frequency of urination, no dysuria, nothing, we call that asymptomatic bacteriuria. So it's really important. I think I see people trying to treat asymptomatic bacteria when the patient is admitted to a hospital or they come through the emergency department. Sometimes people come in, and rightfully so, the emergency department doesn't know what's going on right away, so they'll check their urine. Oh, the urine looks positive. Let's send for culture. But then sometimes we forget to do the basics, like ask the patient, do you have any symptoms? Very, very, very key. Sometimes the patient can't answer. In that case, it becomes more difficult. However, we want to not forget to ask the patient about his or her symptoms. So let's go deeper. So this is the pubic symphysis. This is like a cross section of kind of the bladder, rectum, uterus. This is a female. So this is the pubic bone. This is the bladder. This is the vaginal opening in the uterus, and this is the rectum. So how do bacteria get into our bladder? Because it's not necessarily supposed to be there. So bacterium from the rectum comes, and I mean, in women, all of these openings are very close together. So the bacteria from the rectum travels kind of to the vagina, and as well as go up into the urethra, into the bladder. So for women, they have a short urethra, so it's very easy for the bacteria to get there. But normally, it doesn't stay there, because when you actually urinate, the bacteria just comes right out. And then you don't have any bacteria there. So when do we get infections? So you're telling me you kind of transiently have bacteria there. So what happens? So when we have bacteria that comes from the rectum and infects the bladder and it stays there, we call that an ascending infection. Okay? However, you can get infections where you're very, very sick. You have either candida or fungemia or bacteria, which we also call bacteremia, and it can see the kidneys down the ureters into the bladder, and we call that a descending infection. So sometimes we see that. Usually the infectious disease team is involved in this point, but yeah. Okay, so let's talk about anatomical risk factors that increase the chance of someone having a urinary tract infection. First, foreign bodies. So this could be anything from stones in the kidney, bladder, or urinary catheters. So as we just reviewed, bacteria normally goes into the bladder. However, if there is a stone there, or if there's the presence of a catheter, when you actually empty the bladder, instead of the bacteria exiting the bladder completely, it will attach to the stones or the catheter, therefore making infection in the bladder, giving it a higher chance of having infection in the bladder. Additionally, sometimes people have congenital abnormalities such as the vesico-ureteric reflux. So basically, urine is supposed to go from the kidney to through the ureter into the bladder and then out of the body through the urethra. There are valves that prevent urine from leaving the bladder and going back into the ureters. This is, however, in this condition, if those valves aren't working properly, that can also increase your risk of getting infection too, because that, like I said, bacteria does get into the bladder. So if unfortunately the urine or bacteria that's normally in the bladder that gets flushed out goes higher up into the urinary system, it can cause infection. Next, or short urethra. So this is the problem with women. There is a very short space between the outside world and our bladder. So in general, bacteria from the skin around the urethra opening and the rectum can easily go up into the bladder. And lastly, incomplete or delayed bladder emptying. So this is a problem because if the bladder isn't emptying normally, there's an increased risk for the urine and the bacteria that's in the bladder to go higher up into the urinary system. So it's important that you're urinating as normally as possible in order to prevent urinary tract infections. So other risk factors for urinary tract infection include the following: having diabetes. So in general, when someone has elevated blood glucose, it really does impair how well white blood cells work. Therefore, it will impair how well someone's infection can be treated. So really, in general, diabetics are going to be at higher risk of infection. The other thing with diabetics is some of the medications used to treat their diabetes will result in glucose excretion in the urine. So basically, the urine is sweeter than it normally is. So in that case, it's really, they have an increased risk of candiduria. Next is sex. So, especially for women, like men, because they have a penis, they have a long urethra. But for women, again, not only do you have your skin and your rectum contributing to bacteria in your bladder, but now you have another person's skin and their flora, so that can increase the risk. The other thing is spermicides. So, for some contraception, this could be an issue, as well as pregnancy. And pregnancy is just you have your growing baby in your stomach, and that just puts a lot of pressure and changes the way that you're emptying your bladder. And just in general, that can increase your risk of urinary tract infection. So let's talk about symptoms. So for lower urinary tract infections, you're going to ask your patient, are they having increased frequency of urination? Is it painful when they pee? Are they having suprapubic tenderness? Well, you're not going to ask them. You're just going to ask them, do they have lower abdominal pain? Where is it? When you're thinking about upper urinary tract infection, they're going to tell you they're going to have the same symptoms as the lower urinary tract infection. However, if you see fever, flank pain, rigors, then you need to be thinking that this is a little bit more complicated. And when I mean upper urinary tract infection, I'm thinking kidney, upper ureters. Anytime I see fever in the setting of urinary tract infection, I'm automatically thinking upper urinary tract infection. Because in general, the bladder normally gets like transient bacteria. So just because you have a little bit of inflammation there doesn't mean that you should be having fever. However, if I'm seeing fever, then I'm thinking, okay, this is a little bit more serious than a regular cystitis, for example. And that's what we typically call lower urinary tract infections. And for upper urinary tract infections, they include pyelonephritis or infection of the kidney. So upper urinary tract infection could be a little bit more complicated. You can have abscesses around the kidney, but in general, we're going to use these two terminologies. All right, so let's talk about some of the organisms that can infect the urinary system. So our biggest one is bacteria Enterobacteriaceae. So this is pretty much your GI flora. So E. coli, Klebsiella, Proteus, Enterobacter, these are all gram negatives. The other thing that's not on the slide and is not part of this group is Pseudomonas. It's another common cause of urinary tract infection. Now, you also can have gram-positive, like Enterococcus species. This is a huge one. Staph, MSSA, MRSA, coagulase negative staph, possibly if you have a catheter in place, because like I said, the coagulase negative staph is typically found in the skin, and you can get skin organisms causing urinary tract infection. And then the Corynebacterium urolithicum. So these are all gram positives. And remember, especially with staph, like if you see Staph aureus is not the most common cause of urinary tract infection. So if you see Staph aureus growing in the urine, your spidey senses need to go up. Could this person have had bacteremia? Is this a descending infection? It's not absolutely always, but you want to be careful and you want to think about it. I think the majority of the time I've seen Staph aureus in the urine is in the case that it's been like a bacteremia or infection elsewhere, the patient became bacteremic and seeded the kidney. So just something to be aware of, to look out for. All right, so let's talk a little bit about diagnosis. So when you're thinking about, okay, could this person have a urinary tract infection? You need to ask yourself these two questions. One, does the patient have symptoms of UTI? This is so important. And when we are in more complicated situations, we forget this basic thing. Ask the basics, especially in the hospital. That's when it really happens. Then, does my patient have a urinalysis or urine culture consistent of infection? So one common mistake I see is the person comes into the emergency department. They get the UA. Okay, the UA looks positive. It has plus leuks, a lot of white cells, and then they don't get a urine culture. They just automatically start them on antibiotics. So how do we diagnose? So our dipstick or our urinalysis are going to have leukocyte esterase or nitrates. And when we do our microscopy, we're looking for over 100,000 coliform units per ml of bacteria. Okay, we want to see a lot of bacteria, and this is going to be the case for most people. However, you can accept a lower bacterial load in someone who has a catheter. So that is because that can be a little tricky, because we'll go over that, but that's going to be tricky. And then you want to see white cells, over 10 cells per high-powered field. Don't forget to send the urine culture. Okay. All right, so let's talk about treatment. So uncomplicated cystitis. So we're just talking about bladder infection. So our first-line therapy is going to be nitrofurantoin, typically given for 5 days. Fosfomycin, I just found this image on the internet. You're given 3 grams once, because for fosfomycin, that is going to last you 3 days. You give it every 3 days, and then you can give Bactrim. Our second-line therapy is our fluoroquinolones. Here, levofloxacin is pictured. Look, fluoroquinolones are a good class of antibiotics, but we don't want to give them first line for a couple of reasons. One, we know that fluoroquinolones are increasingly becoming a risk factor for Clostridioides difficile or C. diff infection. Also, certain people get Pseudomonas urinary tract infections. And our fluoroquinolone class happens to be the last oral antibiotics that we can give before we have to do IV therapy. So we don't want to put a lot of fluoroquinolones out into the system, especially someone who's, because if they do grow Pseudomonas, we want to be able to give them a fluoroquinolone, because what happens when you become you have Pseudomonas in the urine and you become resistant to our fluoroquinolone class. Every time you get a urinary tract infection from Pseudomonas, you have to get IV therapy. So that's not fun. So we want to reserve this class. Next, our complicated urinary tract infection or pyelonephritis. This is when you want to put the fluoroquinolones. Fluoroquinolones concentrate really well in the kidney as well as Bactrim. So reserve reserve the fluoroquinolones for your more complicated infection. And Bactrim you can use for cystitis or pyelonephritis. So these are just a few antibiotics. There are a lot of different antibiotics. You can use doxycycline, you can use cephalexin. So there are a lot of different types of antibiotics. When you get your culture, you're going to get susceptibilities, and based on that, you can decide if you want to change therapy. But these are just some empiric treatment, because I do recommend, especially if you're seeing a patient in the outpatient setting, if someone is symptomatic, you collect your urine, do your urinalysis, do your urine culture, and start them on therapy immediately. Don't necessarily wait for the urine culture if they're super symptomatic. All right, so what about asymptomatic bacteria? So IDSA, or our Infectious Disease Society of America, recommends the following. So in general, don't ever treat or screen for asymptomatic bacteria. Like, do not screen. Oh, could they have bacteria in their urine? No, don't do that, except for in the following cases. So if someone is pregnant, they recommend screening at the initial visit. If it is present, you can give a 4 to 7 day. You're going to give a longer treatment than your typical uncomplicated cystitis in women treatment. And antibiotics that are safe are nitrofurantoin, beta-lactams like cephalexin, and fosfomycin. Typically, we're going to allow our OB colleagues to take care of this because they do it every day. Next, especially in outpatient setting, you may get a pre-op referral for one of your patients that's going to undergo a urological procedure. So in this case, you should screen someone who you know is getting a urological procedure that could potentially cause mucosal bleeding. You want to screen and treat that person for infection. This is because, and we see this commonly, if the patient has bacteria in the urine during these procedures, this bacteria could easily cause infection and make the procedure, unfortunately, more complicated than it has to be. All right, who don't we screen? All right, diabetics, please, please, please don't screen diabetics. People with chronic catheters, suprapubic catheters, prolonged Foley in the hospital, just chronic Foley, intermittent, people who do intermittent catheterization, people who use condom caths, do not screen, please, because it only takes about like 24 hours for the bacteria that's in the bladder to attach to these things. So they're going to always be positive. Their UA is going to look positive. The urine culture is going to grow something. If they don't have symptoms, don't worry about it. Additionally, our elderly. So when you're postmenopausal, you have an increased risk of having urinary tract infections. So if they're not complaining of symptoms, please don't screen. Please, please. Additionally, people with spinal cord injury. This is another group that they have an increased risk of not emptying the bladder completely. So if you're not emptying the bladder, bacteria that normally is there isn't being eliminated immediately, and that can increase your risk of infection. 1. 2, if you're not having symptoms, it can increase the chance of you having a positive UA and you seeing bacteria in the urine culture. So don't do it. Don't do it. And lastly, young premenopausal women. Don't screen. Oh, okay. And people don't typically do this, but like I said, urgent cares and emergency departments are sometimes problematic. They'll say, oh, well, this person has fever. Let me just see if they can have a urinary tract infection. No, please don't do that. Please make sure they see if they have symptoms. Don't forget the basics, okay? All right, so now let's talk a little bit about catheter-associated urinary tract infections. So here are IDSA guidelines. 1, if you're going to treat, we typically give 7 days of treatment. In addition, please remove the catheter. And in some patients who that is not possible, it must be exchanged. So let me actually harp on this point. Let's say someone has a chronic Foley. If you're trying to diagnose a urinary tract infection, it is important that you do not obtain the urinalysis or urine culture through the dirty Foley or through the Foley that they came in with, because it's contaminated. So the proper thing you need to do is exchange the Foley, then get your urinalysis and your urine culture. If you were like, dang, I didn't realize that I got it before, that's okay. Hold antibiotics, Exchange the Foley, then repeat this. Because if you get in these tests through the dirty Foley, I don't know if the bacteria that is growing there is coming from the bladder or is coming from the bacteria that's colonized the tube of the lumen of the catheter. However, if you exchange the Foley and then get these studies, I know like, okay, it's a brand new Foley, so it hasn't had time, bacteria hasn't had time to colonize it. So from that sample, I know that whatever grows is a true pathogen. So please do not forget that. Last, in general, please try to avoid putting Foleys in people, period. And if that's necessary, please limit. All right, so a few things about recurrent urinary tract infections. This is probably very, very, very challenging for patients, very challenging for primary care providers. So let's talk about this. Someone comes into your office and they're like, look, doc, I keep getting urinary tract infections and I'm tired of it. What do I do? Number one, you need to assess for stones. So if someone keeps coming in with the same organism, like, okay, well, dang, this person has had E. coli urinary tract infection 3 times this year, you need to look for a nidus of infection. Because typically, like, remember, if you have a stone there, bacteria will harp on there, and as you're treating it, you're going to clear the urine, the patient's going to feel better. However, once you remove the antibiotics, that bacteria is still there. You can't sterilize that stone. The stone has to be removed. So you want to look for stones. So specifically, you want to do a non-contrast CT of the abdomen. Alternatively, you can do a renal ultrasound to look for this. So this is, and then if you find a stone, you need to refer this person to urology. You refer these patients to urology and say, hey, this person keeps coming in with recurrent urinary tract infections. Is there anything you can do about this stone? Second, you want to think about, does this person have an enlarged prostate? So this is very common for elderly men. However, if the patient is now getting recurrent urinary tract infections because of their prostate, then that's a problem. That's another person that needs to be referred to urology. So the issue is, this is an example of someone who's not emptying the bladder properly. So remember, the prostate kind of encircles the urethra of the man. And so if it's enlarged, it can compress that urethra and it makes it difficult to empty the bladder. Additionally, does the patient have pelvic floor abnormality? So this is common in women who've had multiple children, who've had pelvic floor surgeries, episiotomy. So this is something that typically you'll refer them to urogynecology to assess. So you need your pelvic floor to support your kind of lower intra-abdominal organs, including your bladder. So if you have a weakness in your pelvic floor, it changes the position of your bladder. And in that case, you can have difficulty emptying and voiding normally. So again, abnormal voiding. So this is something that needs to be addressed by our urology colleagues. Additionally, let's say they're involved with urology and they had a stent for some reason. Sometimes the patients are lost to follow-up and the stents aren't removed for whatever reason. Or, it's a more complicated situation that a stent is needed. Again, this is another urology issue. Lastly, was the patient treated correctly? Okay. If you have a renal abscess, I'm going to give you antibiotics longer than if you just had a regular uncomplicated pyelonephritis or a cystitis. So you have to look, okay, with this last urinary tract infection, did the patient receive long enough antibiotics? Number one. Number two, did the patient receive the correct antibiotics? So sometimes people will give the patients empiric course of an antibiotic. They'll get the urine culture and then they don't follow up on the urine culture. So you, being an astute medical provider that you are, go back to the urine culture and realize, hey, this person was given an antibiotic that their current infection is resistant to. So just go ahead and treat that person properly. Third, did the patient take the antibiotics? So, okay, well, I felt fine after day 2, so I stopped taking the antibiotic. If it's a more complicated infection, that can lead to incomplete treatment. So those are some of the scenarios. And lastly, I don't have it up here, is postcoital urinary tract infections, or basically women who come in, they say, look, every time I have sex, I get a urinary tract infection. So this could be a challenging thing. The couple things that I would do initially is, number one, make sure that that person is well hydrated. Because again, the more you drink, the more you pee. The more you pee, the more you're going to eliminate bacteria from your urinary system. So that's one. That's number one. Number two, if someone is having these infections, they should really make sure that they're avoiding after sex. So sometimes, you know, you want to cuddle, you want to do all of this thing. No, like after you do, go to the bathroom, you know, and make sure you void, because any bacteria that transiently got into the bladder while you were having sex, you'll be flushing that out. And those two practices will probably get rid of a lot of infections, your postcoital urinary tract infections. However, let's say this person is already like doing all of these things and they're still having infection, and you've looked for all of these other things that could be causing, and they don't have any of these things. Sometimes in those cases, you can give them antibiotics that they can take after sex, just a one-time dose of nitrofurantoin, for example, or Bactrim. All right, so when should you call your friendly infectious disease consultant? All right, if the person has a perinephric or intrarenal abscess, because this is a more complicated infection, you want to make sure that they're treated properly. Sometimes they need to be seen as outpatient, and I love our primary care colleagues, but we as infectious disease doctors see this all the time, and we're more than happy to see this patient for you to make sure that their infection is treated properly. Additionally, if a person has a urinary tract infection secondary to Staph aureus or a multi-drug resistant organism, please call us. We're more than happy to help. This is something that's a little bit more complicated than what you typically see. If the person has bacteremia, this is probably me being like more cautious, but depending on the type of bacteremia, they may need echocardiogram. Next, if someone has obstructive uropathy, so basically if someone has infection in the urinary tract in the setting of a stone that's blocking the flow of urine from the kidney into the bladder. That's what we're talking about in regards to obstructive uropathy. This is a urologic emergency. As soon as, let's say you get your non-contrast CT and the radiologist, you see this on the radiology read, the first call you need to make is to urology. Like literally the first call you need to make is to urology. And then you call, the second call should be your infectious disease colleagues. But again, first call urology, second call infectious disease. And we're more than happy to see this patient. Next, if the person has like tuberculosis or a mycobacterial infection, this can be tricky to diagnose, but this is a more complicated infection and we definitely need to see this person. Or if there's a urinary tract infection that you're just really not sure about, you really have questions with, patient's not getting better, just any questions, please feel free to call the infectious disease team. We're more than happy to help out. All right, so that's all I have for you. For more additional information, please make sure you check out my IG account at dr_kbird. Additionally, if you enjoyed this video, please like the video and subscribe. Make sure you sign up for the notifications. There will be more to come. All right.